Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about what's it mean to actually be an evidence-based practitioner or a clinician. There's a lot of debate about that, where we go full evidence versus blending things, experience and patient preferences. But before we get too much into it, Brandon, how's it going?
Going well, Jay. Happy to do this episode, be here with you. I love this topic we're going to do today. I actually did a IG live, a short mini one about a week ago or so on this. Actually, by the time this podcast airs, it'll probably be a few months back.
Yeah.
But yeah, there's a lot of controversy around this, misunderstanding, really clinicians only getting a piece of the puzzle and things like that, especially when it comes to social media. And I think as leaders in the field, as two clinicians who not have only done the business side, we have climbed the top of the clinical mountain, at least in certifications. And I say that with air quotes for you people listening. Obviously, certs don't mean anything, but we have our fellowships, and that is a rigorous program or criteria to finish. And one of the big things in a mission statement for becoming a fellow is not only evidence-based practicing, but becoming a leader in our profession. So I think hopefully Jeremy and I are doing a good job with that. But yeah, that leads us into our drinks, man. What do you got, Jay?
So today I got a beer from a patient. So very nice. Jean Marie. This is shout out to you. I doubt you listen, but shout out to you. I love her because she busts Justin's balls pretty regularly at the clinic. So she automatically becomes one of my favorites. It's Mama's Table. I have no idea what it is. This is, I guess, a kind of a small crowler version of it. It's Backwards Flag, which is one of my favorite breweries of all time. A military or veteran owned up in Forked River, which I went to many years ago in the very early start of my brewery. I guess love there. But Mama's Table, a shout out to my mom. This is kind of related to sort of things of she always said, whatever you do, be the best at it, whether it's flipping burgers or eventually I guess being a PT. She's like, try to be the best at it. So I think that's a lot of what trying to be an evidence-based practitioner really is it what's the best way to be the best at what you do, in a sense. But so shout out, Mom. I'll let you know my score. Brandon, what about you? You have what looks to be a pretty awesome bottle there. So let's hear it.
I have, drum roll, I guess, here.
Oh, so sorry. All right.
No, it's all good. Clase Azul, reposado. I'm going to pay homage to Mike De La Cruz, former intern, absolute just stud in the clinic and in the weight room. Really, did an awesome job with his affiliation. He's going to be a stud PT. I'd love to have him on. I told him I'm hiring you already, so he has no choice in the matter. He's stud in the weight room too. We call him Baby Rock, and he a lot of people think he looks like my cousin too, so he's gotten the name Primo as well. So quite a few names, but he went all out on his last day, got me this lovely bottle of Clase Azul, wonderful tequila if you guys haven't had it. A little sweet at the end there. So Mike, I know you've been waiting for this moment, so bask in your glory, bask in the ambiance here. Cheers to you, brother.
Cheers.
That's smooth right there. So he's been asking me, dude, when are you gonna do it? When are you gonna have my drink on your show? I'm waiting. So I said, pump your brakes, pump your brakes. I'll get you on.
You get a lot of flack for that.
Oh yeah, if they know, it's like they give it to me and they want it the next episode. I'm like explain to them, hey, what you're hearing is pre-recorded or recorded and it has to be put out, yada yada. So I'm like, you'll get there.
Yeah, no, I typically with the beers, but I don't get too much flack for it. Maybe Pat just gave me some. He just wrapped up, and he's just like, "Listen, you can't have this unless it's for the actual podcast, but they're like barrel aged style ones. So when they're big, maybe like I think they're slightly bigger than a typical can, and they're like 13-14%. They're like barley wine style beers or porter or like bourbon barrel aged stuff. So I mean, not unless we're doing one at like 6 o'clock at night, I'm going to be pretty wrecked for the rest of the day if I put one of those bad boys down, because you can't just cap it. It's once you open it, you're gonna have to, you don't want to waste.
Got me that big can that's like what, 32 ounces or something, that we're gonna have
real
to do
big ones, like a crowler.
I don't know what it was. It was that blonde porter you got me. It's like a thick freaking can.
Yeah, so that's a crowler.
Right. Yeah. So
I
need to have that. That's definitely an episode. We might have to do a night or weekend episode and shoot like 2 or 3.
Oh yeah.
To finish that, and then you could have your drinks you're talking about. But
and
yeah, I take the flack as a good thing. You know, they're excited. They got me, you know, whatever drink they got me, they want me to share it. They're waiting for their shout out and pay homage. So I get it. I love it.
Awesome.
Keep it coming. So, all right, let's get enough of the ranting here. We'll jump into the episode. Yeah, what's up?
I gotta get my rating. This is an excellent beer, a pumpkin and yam beer. I had to look it up.
Oh.
I am going to give a 9. That's how
that's all time.
The 9 point, which may be the highest all time.
Yeah.
I'm gonna give it a 9 because it's that good. It like literally took me back. It's got like a touch of cinnamon into it. But excellent beer. So going back,
is it like a pumpkin pie beer?
Is it? I don't know. I didn't want to look up too much of it. I don't want to be distracted. But I was first just gonna rate it, but then I was like, "Damn, what is this?" And I had to like type it in and find it on Untapped, which apparently didn't get that high of ratings as much as I would give it. But you know, that's just me. I go against the grain a lot in life, but I never had a yam beer, so I thought it was really good. So kudos to Backwards Flag. You have the highest rating thus far.
You know what? I'm going to go on and say whatever you just said, right? Going against the grain in life. Here's a little tidbit. And is, I guess, a little oxymoron because I'm giving advice that you would follow, but I'm saying go against the grain with Jeremy. You want to get ahead in life. You want to, break the herd, start doing opposite of what most people are doing. You're going to be looked upon weird. People are going to question you. What are you doing? Why aren't you out, doing X, Y, Z? If you're doing opposite, if you're getting questioned, you're on the right track. Mm-hmm. And a lot of people don't see it, man. So great words, Jeremy.
Thank you. So, but yeah, hopefully we're doing that. I think we are, especially with our clinical practice. And I guess speaking of which, because I know we've done some things that people have found pretty interesting or different, especially in the scope of manual therapy.
Yeah.
What would you say is, I guess, your basic interpretation of evidence-based practitioner, or take us off on this one?
Well, that has changed for me. I will be honest that, from entry level where you're taught it's meta-analysis, randomized controlled trials, systematic reviews, we should only follow the top of Sackett's pyramid that he creates, right? Mm-hmm. Then it kind of evolved to reading the evidence and following just CPRs and CPGs like they're God's word. And now, I take everything with a grain of salt, and I rarely look at randomized controlled trials and meta-analysis. They don't really mean anything to me. Mm-hmm. They actually, if you understand what they're actually looking for, you understand you probably shouldn't follow them as God's word when it comes to your interventions to a patient. We'll get into that a little later. So my I guess meaning and definition has evolved over time. I think like anything else with experience, and then you develop what kind of works and you get your own pattern recognition. Mm-hmm. But one thing that has always stood out to me since I read it, which was early on in fellowship, so it was late 17 or early 18, was Phil Sizer's article. And I always reference this article. I've probably referenced it many times on this show. We talk about it in our courses. We talk about it on our mentorship calls and things like that. And to quote him, evidence-based practice was originally developed to increase the use of epidemiology and stats in clinical practice. It was never intended to de-emphasize the clinician's expertise, patient biology, patient values, and beliefs. Right? I think we've gone away from that. And we've also integrated now in the realm of physical therapy, biopsychosocial model. But everyone, or not everyone, but a lot of people are, getting rid of that bio and just focusing on the psychosocial model. And then that leads to a hands-off approach. Obviously, we're manual therapists, so we have a bias towards manual therapy, but it also has its place in time. So there's a lot of different layers to this conversation, and I obviously just kind of went into that and touched upon a lot of different things. But before I continue, how is your experience with evidence-based practice? How has that evolved, and what does it mean to you today?
I mean, initially, when I first came out of school, I don't know, I guess I was so resistant to research. That was my least favorite class, which now has completely changed. I'm actually doing research with my research professor down at Stockton. Shout out to Mary Lou, who's amazing. Mary Lou Galantino is an amazing contributor to our profession. I believe she is a FAPTA. That's FAPTA. Which is only given out to the truest movers and shakers of the entire profession. So whether it's oncology, orthopedics, such and so forth. I was just more worried about like the bread and butter at the time. So yeah, we got exposed to it in class, but it was more like, what can I figure out on my own earlier? And I just take what I can get from PT school and just apply it. That was my extent of things. And then unfortunately, I mean, my outcomes weren't as good, and went to residency and started really giving us articles. Because I would be honest, mostly what I read some stuff outside of things in PT school, but it was mostly the lectures and here and there articles. But it wasn't until residency where articles were given and you're, challenged on them and you had to put your viewpoints on them. That's really kind of finally instilled the idea of evidence-based practice. And I definitely went probably too ham on that, where I had to have my, rationale or what I put into my plan of care or my clinical decision making had to have purely something that was backed up by evidence. A lot of eccentric loading for like my strains and that sort of stuff. Or like Achilles tendinopathies and all those sort of things, and it didn't let me waver as much as I could. I mean, obviously, as people weren't getting all the way there, I'd tweak some things, but as I continued to evolve and start to really understand that, it's that whole blend of, especially the patient experience. Obviously, my experience as a clinician is huge. But once you start to understand that there's no research to ever replicate someone's personal experience, that true N of one, there's nothing that's going to be able to say like this one is exactly for you, unless the research article is they were involved with it, a couple of years beforehand. That once you start to really understand that, that's when you really start to need to look at things of that whole blend that you were discussing. When I was picking my fellowship, I remember me and you were talking to Toko of IAR, and he came in and he was saying we're more of an evidence-informed type of fellowship, which at first, I was like, no, that's not really my thing. I'm EBP. That's why I got in residency. We're heavy on the research, but him explaining his rationale of things of like, yeah, you can go in with the research and that sort of stuff, and it's not succeeding, someone's just going to go off to the next person, especially your athletic population. So that hit home with me, and they definitely implement evidence and research into their things, but they're looking at it from what they experience as clinicians of 10-20 years in the sports realm. So that really hit home for me. Yeah, it's really truly, I think, for someone who, as me, who's played around with a lot of different, I guess, methodologies in physical therapy, where I've had a period where I was kind of hands-offish. I had listening to previous episodes, I had a overkill of pain science. I had a overkill of eccentric loading. I had a isometric phase. I've had all these phases, not to say I just tried a new flavor of the month, but I kind of sort of did at one point where I wanted to see was effective. And when you really start to realize it is, treat the person and implement all these different things, that's when you have the best outcomes. And a lot of that isn't, found in the literature. You can't find stuff of like, a patient that was, beaten as a kid, found, a spouse that does it, and, the impact that has on them in their, in their therapies and that sort of stuff. Or go diving into the certain things I see of like ACLs of, previous, back pains or episodes, then a lot of them have ACL tears. Is that something related? Is that something I need to treat? Well, there's not a lot of research into it. But I know when I start to treat, they seem to respond better. They're in less pain. So that's kind of my evolution, which was a little bit long-winded, but yeah, hopefully that made sense to a lot of people.
Yeah, and it's all true. I think one of the bigger things with that is tying together multiple experiences, whether that's, what you've experienced as a person or through your growth and evolution as a person, sports, education, things like that, your patient's experience, their beliefs, what the research says. And when it comes to the research says, it's not just pointing to one or two articles or citing one or two articles. I mean, that's easy, but being able to take articles or read an article and read multiple articles and see where the overlapping or the commonality is and also the differences are. So, because an article is going to have, especially a randomized control trial, right? It's going to have rigid constraints on it. Right. And that's to make the internal validity better. Right. But we don't practice in a perfect, ideal world. Right. There's a lot of other factors. So you need to be able to take different parts of, I'll say, research and be able to find not necessarily the holes, but if one study looks at one thing and another study looks at another thing, well, where are the overlapping components? Mm-hmm. Not only that, now take that with this patient that may look like three other patients that you've had and see what are the commonalities there and what are the differences there? Mm-hmm. And then also taking your own bias and own experiences and own skill set and own training, analyzing, synthesizing that, reflecting on all three, and then somehow melding it to apply an intervention to hopefully yield an outcome. Mm-hmm. I think that everything is too much in silo. Mm-hmm. And that's PTA in a nutshell. We're a siloed profession. It's this camp, it's this camp, it's that camp, it's this specialty, it's that specialty. Like, I don't think we come together enough as a profession. Mm-hmm. And it shows in the way things are synthesized and the arguments that are had. I mean, we talked about on this show, two heavyweights and Adam Minkins and Chad Cook arguing about what's the more superior intervention, when in actually, both are probably good. Depends when you're using it, how you're using it, who you're using it to, at what point in time you're using it. I think part of evidence-based practice goes into clinical reasoning, clinical decision-making. Reasoning needs to not be linear. And I think too many therapists are linear in their thought process. You have patient X, they present with Y symptoms. I'm going to look at, Z research, and then I'm going to implement that. And it should work. Instead of understanding that all this stuff is dynamic and the patient's presentation is dynamic and the response to treatment is dynamic, and what you decide to follow up with needs to be able to kind of change on the fly. So you and I don't treat to pathologies anymore. And a lot of PTs are stuck in pathology. I think that's a barrier in evidence-based practice. While the evidence says this for this type of pathology. Mm-hmm. Well, it also says to look at impairments, and it also says treat the patient. And it also, if you look at the BEEP biopsychosocial model, there's many spokes coming off of that patient-centered care. Mm-hmm. Right. So we can't just look at, one or two things and then call it evidence-based practice. for the therapists out there that are, anti-manual therapy or pro pain science, great that you're harnessing those skills, but if you're just doing one thing, you're missing and alienating so many other facets that can help aid in your treatment of patients, and that becomes evidence-based practice. This conversation is evidence-based practice. The conversations that you have with your peers in the clinic, on a podcast, listening to a podcast, going through some type of program, is all forming and shaping the way you think, the way you reason. That should be included in evidence-based practice as well.
I love that. I think that thought process of, just conversation amongst clinicians is evidence-based practice. I had some great mentors where a lot of it wasn't really as I was currently treating someone, it was the conversations afterwards, conversations where I was challenged or brought up some ideas to make me better, which is awesome. Brandon had a conversation with a PT, which we'll not name on the show, but he mentioned that he has 6-7 clinicians at his place, and mentioned that their outcomes for a certain thing was good enough, or was always good enough. And I've mentioned it, probably mentioned it on the show, is it should never be good enough. You should always strive for more. You should always leave a percent of your practice or your session with a person for some sort of something that may potentially be new. You don't have to reinvent the wheel. Sometimes consistency is key, but you're looking for a way to get that person better fast, whether it's loading them a little bit quicker or more strategically, because loading them too quick may irritate some things. So more strategically, playing around with your manual therapy. We've talked on the show that, God, if we really were able to put out a lot of research, we'd have, probably 20 techniques between me and Brandon with our own names behind it, as the Boyd maneuver, Boyd technique, the cruise crack, things that we've played around with, not just for, obviously we don't do it and publish it for the sake of our own names, but for the sakes of our patients getting better. It's trying to find the quickest, fastest option. I think that's where a lot of the magic happens, and I think that's really, there's no evidence to support those sort of things, but you're searching for improved evidence with yourself. And you always want to reflect. I always take some time in the year to look at my previous notes and what I did during the year, or what I used as interventions and that sort of stuff, or even examination techniques, and I can start to see my evolution on a year-by-year basis. So that in itself is, you're your own case study as a clinician. Reflect on these sort of things, and that becomes your evidence. And hell, you can run statistics on it. And we had to do it for residency and that sort of stuff, fellowship and everything like that, where take people of the same pathologies, or if you want to label it like that. I wholeheartedly agree with Brandon. I don't treat people on pathologies. I treat based off of areas and impairments, and I've had a lot more better outcomes in that. And also, on a side tangent, that think about how limited your research is, because a lot of the inclusion criteria is based off of somebody's diagnosis. So it's a pathoanatomical diagnosis, which a lot of the times is incorrect. These diagnoses were made, God knows how long ago. Sinan Larson's, Osgood Schlatters, all these sort of things were made by guys, 50, 60, 70, 80, 100 years ago. Yeah. But going back to us, and it's like, try and categorize them. Here's my knees, let's say anterior knee pain. Here's my Achilles pain areas. Here's my plantar fascia or dorsum of the foot, or plantar aspect of the foot pains, and start to track how long is it taking you to get them better. What was their length of stay? And if you want to use outcome measures, by all means use outcome measures, and allow that to be part of your evidence, of you trying to get those numbers better, because numbers don't lie. to some degree. So, use that as a way to self-work on your evidence in a sense. Ideally, hopefully, the way you do it and get faster is incorporating some research, bouncing ideas off of, mentors and other clinicians, and then just really listening to patients. They'll give you, if you're asking them, they'll tell you which intervention is helping them the most, whether it's a home exercise program. I know initially when I first was giving out HEPs, one was good, two or three would piss them off, which was in the intention. Oh, maybe not two or three, maybe in certain cases. So I'm like, all right, well, we definitely want to do the one, get rid of the two or three. And now it's, all the exercises I give are, not aggravating things and only making them better. And that's from a lot from listening to patients. What were the ones that have the, highest reward and lowest risk for that particular impairment? So yeah, definitely do a lot of self-reflection. Again, I believe is a form of evidence, especially a way to enhance clinician experience.
Yeah, self-reflection. And I think in that, also listening or following people, podcasts, whatever the case may be, that don't necessarily align with your views, because chances are they're going to say something. Maybe it's not everything, but something that you agree with, or maybe makes you think differently. If you're just totally tunnel visioned and biasing yourself because all you listen to or follow or read is things that you agree with, and not looking at the other side of the coin, that's a problem. If too many PTs tend to just read the abstracts or jump to the conclusion and not read actually what's going on. I get it. Nobody likes to read articles, but that's partly what we need to do to become evidence-based practitioners. And if you're not going to do that, well, then you need to listen to the different facets out there. I would say, yeah, evidence-based practice takes, it does take thought, it takes discipline to learn and to integrate. But when you're able to do it, it becomes easier, and you become a much more seasoned and effective clinician.
And it's more fulfilling. Like we talk about burnout all the time, and we say, is it, based off of productivity and numbers? I think it's, if you're seeing, let's say, something outrageous, you're seeing 50 people a day, just working like a workhorse, but every single one of them was making excellent progress. They're super happy with you. You'd probably wouldn't feel too burnt out. I'd guess maybe the paperwork would probably burn you out to a degree, but if you're doing these sort of things, and you'll get excited about it too. Like I get excited. I was like, oh, I read something case study, I thought that was pretty interesting. Whether it's a diagnostic one, like finding some, I think the JSPT case studies, like resident cases where they're pulling up some obscure, crazy diagnosis and that sort of stuff. I'm sure, like, I've had those cases where I was one who found something that was not really maybe in the scope of our practice, whether it's cancer, not spina bifida, cauda equina, those sort of things. When you're one that finds that, it sucks for that individual, but the one that, if you're finding, you're like, damn, that was pretty damn cool, wasn't it? Or from a treatment standpoint, I did something, or I played around with it. I saw how I did things with Mary. I applied it at the gym and tweaked it a little bit, and boom, he's like 90% better in the first session. That's going to only fuel you more, one, about your job in general, but to further go down that rabbit hole of what we believe is evidence-based practice. So do it for yourself in a sense. Be a little bit greedy, and believe me, you'll find more joy as you do it, for sure. Again, I mentioned research was not my favorite class in PT school. I did not really enjoy it very much, and now whether it's case study presentations that me and Brandon do all the time, now we're getting more and more advanced, and hopefully developing some algorithm stuff to help out examinations. So that'd be something I never in a million billion years that I thought I was going to enjoy. But now once you get involved in the process and see the impact it can have, it really just fuels you to do it. So, keep all that in mind.
Yeah, I think we've talked about this next point as well. I mean, being able to elevate our understanding and our applicability of evidence-based practice, what it is, what it isn't. Chances are it's probably some form of everything we're talking about. Is we're a doctor profession now. More PTs need to start acting like it. More PTs need to understand what that really means. And not just become a cog in the wheel, but take on that onus and ownership of, this is my patient. I'm not going to rely on somebody else unless I need to refer them out. But if somebody's coming to you for pain and they have pain when they're squatting and they want to go back to their trainer or gym, don't just leave it up to their trainer to assume that they're going to do it right. They're in your care for a reason. That patient becomes yours. And granted, you need to worry about referrals and building relationships and things like that, but that person is under your care. So we need to be able to rule things out, understand red flags, not be scared or nervous that something else might be going on, and just refer them out to a physician, especially when we have the tools and capability to screen out or at least identify potential red flags. We teach a lot of courses throughout the year. We hear a lot of different stories, and it's unfortunate. I think it's sad that you get to a case where you could definitely be helping somebody and we're not doing it because we're nervous something else might be going on.
Mhm.
Well, what are those other things you're thinking of? Chances are we have the tools, or at least we've been training the skill set to perform certain screens and rule out red flags, to then understand, hey, is this patient at higher risk? Is this patient at lower risk? What can I do? Is this a treat? Is this a treat and refer? Is this just a refer? And I think some of that, and a lot of that, comes from the evidence, because if you don't know the evidence, if you're not reading the articles, you're not taking that time, you're just going to be another therapist. You're bringing a profession back. We're becoming technicians again, and you're just going to keep referring out. And now you lose that patient, and you didn't advocate for yourself or the profession as well.
Yep. And then that leaves a unfortunate stain on the profession for those particular individuals. We give up too quick. We don't try things. We don't read up things. One of the first questions I ask anytime a student's struggling with a particular client or anything like that, I'm like, did you look anything up for this? Yes, I'm here to mentor you and give you some, feedback and that sort of stuff. And I'll give you some stuff that I think would help, but I want to see that you're doing it first. That should be the mentality that we have. It shouldn't be like, oh, the patient's not getting better. All right, let's just keep treating them for another 2 weeks, or let's send them back to the orthos or whatever it may be. And the patient's not getting better. And then, because you've kind of consistently done the same thing, you didn't change things, you didn't ask for advice and all that sort of stuff. When that patient either gives up, ends up having a costly surgery, or worse, starts getting into opioids or anything like that, they're gonna remember that. I was like, well, I tried physical therapy for like 4 months, 3 months. I had a patient recently who was doing PT for 2 years, and we did a couple of things, and by the end of it, she was like, I feel amazing. So 2 years of going on PT, whether I assume it was on and off, but still, you can only beat a dead horse so much, trying to level up, evolve, and do it for the sake of the profession. So many of us bitch as a profession, like, oh, we don't get paid that much and this and that, we don't get respected much. Well, because we have people who aren't getting the job done. If you're not getting the job done and you're seeing people 3 times a week for 4 weeks and no change happens whatsoever, do we really deserve to get paid more? I don't think so. So really, I think it's the whole profession needs to really kind of push themselves to really become the autonomous, the alpha of treating neuromusculoskeletal issues. And then sorry for the other scopes of physical therapy, oncology, and more neuro-based or cardio, you guys as well. But obviously a lot of what we're talking about is the ortho sports realm. But yeah, I think that's really what we need to do. I mean, it's really not, it's a time commitment, but it's probably really not as much as you think it is. Once you start making that part of your regular life, it's really not that bad at all. Again, a lot of what I do, Brandon, you saw what's on my in my bathroom. I have PT books there. I have sometimes GSPTs. I have some other articles. So, do it there. Hell, everyone brings their phone into the bathroom anyways. So I try not to. That's why there's books instead. Do it 2 for 1 while you're doing number 2. So
there you go. There it is. Well, I guess honestly, there's no following up that. I guess we'll sign up with those pearls of wisdom there by
there you go.
the decent
Become an
doctor.
evidence-based practitioner while you're dropping a deuce.
Beautiful.
That's what I'll name this one. But all right, great. Well, awesome episode. Hopefully you guys gained some things. If you have any questions, comments, concerns, or if you're seeking any mentorship of any sorts, feel free to reach out to us. There will be some closing remarks with our was it intro? Is what you called it once, Brandon?
Sure. I don't even know anymore.
It's not an intro. It's something that happens at the end.
Outro.
Okay, there you go. So we got one of those now. But yeah, thanks for tuning in, everybody, and I guess cheers.
Cheers, guys.